Welcome to The Explainer. Today, we're going to decode the language that doctors use to describe cancer. We're breaking down one of the most important tools in oncology, the TNM staging system. So let's explore it together. Okay, let's just dive right into this. When you hear a phrase like stage 3, it kind of sounds like a simple label, right? But believe me, behind that term is a powerful and really precise language that describes the cancer in incredible detail. You can think of it like a global standard. It means that a specialist in Tokyo can read a patient's file from Toronto and immediately, perfectly grasp what's going on. It makes sure that all these huge treatment decisions are based on a clear, shared understanding. So what's really crucial to get is that staging isn't just about giving the cancer a grade. Nope, it's a super meticulous process, kind of like creating a detailed map that tells doctors the exact extent and location of the disease. And having that map is absolutely essential for picking the right path forward. The system that's used almost everywhere is called TNM. And that coordinate system analogy, it's perfect. Seriously. Each letter, T, N, and M, gives us a specific coordinate that helps us pinpoint the cancer's exact status. So let's break down what each one of them means. First up, we've got T. This letter tells us everything we need to know about the primary tumor itself. You know, the place where the cancer first got started. It's all about its size and whether it has begun to grow into any nearby tissues. The key thing here is that T isn't just a simple yes or no answer. It's actually a scale that answers two really critical questions. Just how big is this tumor, and how far has it pushed its way into the tissue right next to it? And right here, you can see that scale in action. On the left, you've got a T1 tumor. It's smaller, it's contained. But then you look to the right, and that higher T-stage tumor, it's not just larger, it's actively invading the structures around it, like the chest wall or tissues around the heart. So let's put some real numbers to this. A T1 tumor is relatively small, up to 3 centimeters. A T4 tumor, on the other hand, is either really big, we're talking more than 7 centimeters, or it has grown into some super critical structures, like the heart or the main airway. And that difference is vital for figuring out if surgery is even a possibility. Okay, let's move on to N and see how this builds on what we know. T tells us about the main tumor. N tells us if those cancer cells have started to travel through the body's own lymphatic system. N stands for nodes, lymph nodes to be exact. These are tiny little glands that are part of your immune system. You can think of the lymphatic channels as a highway system, and doctors check the lymph nodes to see if any cancer cells have hitched a ride and started spreading from the original tumor. And you can see this clear, logical progression here. N0 is the best-case scenario, no cancer found in the nodes. N1 means it's just in the closest nodes. N2 means it's traveled a little further up the chain, into the center of the chest. And N3, well, N3 is a major flag. It means the cancer has spread pretty widely in the region, which totally changes the treatment approach, often meaning more aggressive therapies are needed. And that brings us to our final, and maybe the most critical letter, M. M asks the biggest question of all. Has the cancer broken free and traveled to distant parts of the body? M stands for metastasis. This is when cancer cells from the primary tumor, in this case the lung, have traveled through the bloodstream and started new tumors in faraway organs. What we see here is M1A, which could mean a few things, like new tumors in the other lung or finding cancer cells in the fluid around the lung or the heart. It's a simple yes or no question, but the implications are profound. M0 means the cancer has not spread to distant sites. M1 means it has. That one singular piece of information dramatically changes the whole treatment strategy, usually shifting the goal from a local cure to controlling the disease throughout the entire body. But hey, M1 isn't the end of the story. The system gets even more detailed. M1B tells us there's a single spot of cancer in one distant organ. M1C is then broken down even further, telling doctors if there are multiple spots in just one other organ system or spread across several. This detail is absolutely vital, as it helps figure out if a patient could benefit from targeted local treatments or if they need a broader systemic therapy. Okay, so we've got our 3 coordinates, T for the tumor, N for the nodes, and M for metastasis. So how did these individual letters get combined to create that one single overall stage number that we always hear about? All right, let's see how this all comes together. We've got our 3 data points, T for the tumor size, N for lymph node involvement, and M for any distant metastasis. Oncologists don't just guess. They combine these factors using a specific, internationally agreed upon staging chart. It's almost like plugging our coordinates into a formula to get the final answer. This chart shows you exactly how it works. I mean, look at that top row. A tiny T1A tumor with no node spread, that's N0, and no metastases, M0, is stage 1A1, which is the earliest stage. Now jump to the bottom. As soon as you have an M1, any distant metastases at all, the cancer is automatically classified as stage 4. It's the combination of T and N that then fills in all the stages in between. But here's something you might not know. This incredibly powerful system isn't static. It's actually a living document that is constantly being updated and refined as our medical knowledge gets better and better. In fact, the system we've been exploring today is the brand new 9th edition, which was just updated in 2024. This reflects all the latest data and understanding from researchers all over the world. And this isn't just for academics. Every update, every little refinement to the TNM system lets doctors make more accurate prognoses and tailor treatments more precisely to each individual patient's disease. Better staging literally leads to better care. And this leaves us with a really fascinating question for the future, doesn't it? As we learn more about the genetics and the molecular profiles of these tumors, how is that going to change staging? The 10th edition might not just include TNM, but maybe a G for genetic markers. This constant evolution is the real engine of progress in the fight against cancer.